62-year-old woman has 5 months of reading difficulties that worsen at night. She has hypertension, type 2 diabetes mellitus, and migraines of aura managed with ramipril, metformin, sitagliptin, and zolmitriptan, and has smoked 10 cigarettes per day for 30 years. On the right-hand side, we can see figure 9, which is an example of a fundoscopic examination of this patient. Which feature is implicated in disease development? A. Choroidal neovascularization. B. Fibrous scar. C. Lipid deposits. D. Retinal ischemia. Or E. Macular edema. The correct answer for question 4 is C. Lipid deposits. We can see in figure 9 the characteristic appearance of drusen as observed in dry age-related macular degeneration. Age-related macular degeneration, or AMD, is progressive disease associated with aging, affecting individuals over 50 years old. It leads to degeneration of retinal photoreceptors, resulting in central vision loss, which can significantly impact daily activities such as reading and recognizing faces. AMD occurs in 2 forms, dry and wet. Dry AMD is the most common form, characterized by the accumulation of drusen, yellow deposits beneath the macula, and atrophy of the retinal pigment epithelium. Over time, this can cause significant visual impairment. Although there is no definitive treatment, oral supplementation of zinc and antioxidants may help slow disease progression. The second being wet AMD, less common, and is associated with severe vision loss. It is marked by choroidal neovascularization, where abnormal blood vessels grow beneath the macula. These fragile vessels can leak fluid and blood, causing macular scarring and further damage to central vision, as shown in figure 10. Risk factors associated with AMD include increasing age, smoking, which exhibits a dose-dependent effect, hypertension, obesity, and low omega-3 and 6. Patients with AMD commonly present with progressive visual deterioration, particularly difficulty reading small print due to central vision loss. A key symptom is metamorphopsia, or distorted vision, which can be detected using Amsterdam grid testing, where straight lines may appear wavy or missing, as depicted in figure 11. Other symptoms may include scotoma, which is characterized by a dark patch in central visual field. A second symptom is light glare and reduced contrast sensitivity, making vision less sharp, especially in bright or low light conditions. The third being disparity in object size, where objects may appear larger or smaller than normal. The fourth, abnormal dark adaptation, leading to difficulty adjusting from bright to dark environments. And finally, the fifth, photopsia, described as flickering or flashing lights, particularly in the presence of neovascular AMD. AMD is diagnosed using a combination of clinical examination and imaging techniques. The key diagnostic modalities include fundoscopy, slit lamp biomicroscopy, fluorescent angiography, and optical coherence tomography. Fundoscopy is a vital first-line examination. In AMD, characteristic findings include drusen, neovascularization, and geographic atrophy. Drusen appear as a yellow-white deposit beneath the retina, while geographic atrophy is identified by well-demarcated areas of retinal pigment epithelial loss. Using a slit lamp with a high magnification lens, clinicians can assess drusen morphology, pigmentary changes and signs of exudative or hemorrhagic activity, which may suggest neovascular AMD. Fluorescent angiography is particularly useful in identifying choroidal neovascularization and leakage. This technique involves injecting fluorescent dye into the bloodstream, which highlights abnormal vessels and areas of leakage in the retina. An OCT provides high-resolution cross-sectional imaging of the retina, aiding in both diagnosis and monitoring therapeutic response. Key OCT findings include epithelial detachment, loss of retinal pigment epithelium, intraretinal fluid, and hyperreflective scarring. Soft drusen, seen as hyperreflective deposits, may indicate progression to advanced disease. On closer inspection to figure 12, we can see in part A a colour fundus photograph of geographic atrophy, secondary to age-related macular degeneration involving the centre of the fovea, with a sharply demarcated area of retinal pigment epithelium, depigmentation with visible choroidal vessels. We can see it is surrounded by large confluent soft drusen as shown by the black arrows within the image. In part D, a cross-sectional OCT scan, shows a loss of retinal pigment epithelium in the area of geographic atrophy, with a depression of inner retinal layers as the outer retinal layers are lost, and increased visibility of Bruch's membrane and the choroid, as shown by the white arrow. The OCT signal is increased below the level of RPE, corresponding to a hypertransmission effect, as shown by the yellow arrow. The large soft drusen is visible on the right, as indicated by the black arrow. Patients with suspected AMD should undergo an urgent ophthalmology assessment within 1 week of referral. Depending on local pathways, this may be through a fast-track macular or retina clinic, or via district general hospital eye services. For patients with confirmed AMD, specific management strategies are determined by whether the disease is classified as dry or wet. If bilateral symptoms are present, notification to the DVLA is required, as per national driving regulations. Management of dry AMD focuses on lifestyle modifications and supportive measures. Smoking cessation is strongly advised, alongside patient counselling and access to visual rehabilitation services. Low vision aids may be beneficial, and nutritional supplementation including vitamins C and E, zinc and copper may help slow disease progression. For wet AMD, the primary treatment is intravitreal anti-angiogenic therapy. Anti-VEGF agents such as ranibizumab are administered via monthly intravitreal injections for an initial 3-month loading phase, followed by maintenance as required. In select cases, laser photocoagulation may be used to target extrafoveal neovascularization, although this carries a risk of permanent scotoma. Photodynamic therapy, which involves intravenous verteporfin and laser activation, is considered a second-line option for cases unresponsive to initial anti-VEGF therapy. AMD can lead to significant visual impairment and blindness, severely impacting a patient's independence and overall well-being. One notable complication is Charles-Bonnet syndrome, where patients with visual loss experience complex visual hallucinations despite having intact cognitive function. The psychological burden of AMD is substantial, with many patients developing depression due to their progressive loss of vision. This, combined with impaired depth perception and contrast sensitivity, increases the risk of falls and fractures, further reducing mobility and independence. The overall quality of life is significantly affected, with limitations in activities of daily living, including reading, driving, and recognizing faces, leading to increased dependence on caregivers. Additionally, treatment-related complications can occur, particularly following intravitreal injections. These include endophthalmitis, traumatic lens injury, and retinal detachment. Patients undergoing photodynamic therapy may also experience photosensitivity reactions.